Right now we will talk about registries and meta-analyses. I have like a presentation just to show the important principles of these methods, and then later we have like a workshop where I will show you how to run a meta-analysis using a statistical software. So as you read here, I'm from Stockholm, and in Sweden we focus a lot on registry-based studies, so I will also provide some examples from the Swedish heart failure registry. That's the registry I work on. So let's start with registries and observational studies. So these slides summarize all the different types of studies that we may run. There are two larger categories. The first one is descriptive studies. The second one is analytic studies. We are more used to analytic studies, but descriptive studies are important as well. So descriptive studies describe frequency, natural history, and determinants of a condition, whereas analytical study describe associations between exposure and outcome. This slide is quite famous. This is the pyramid of the evidence. As you can see on the top, we have clinical practice guidelines. And in order to achieve enough knowledge to build guidelines, we need other types of studies. So we need systematic review and meta-analysis that summarize actually findings from randomized controlled trials. Other important studies reported in these slides are controlled clinical studies, retrospective, prospective cohorts, case reports, case series, and expert opinion. Although we may always focus on the top of this pyramid of evidence, because there we find the strongest evidence, we don't have to forget that each of these different studies is important because allows us to achieve step by step a higher level of evidence needed to run later, for example, randomized controlled trials and then meta-analysis and so on. So all the studies are important. Let's define a registry. A registry is not a type of study. A registry is just a collection, a uniform collection of data. It can be different type of data, it can be clinical data, lab data, and so on. The registries evaluate specified outcomes for a population defined by a particular disease, condition, or exposure. There are two different types of registries. One is disease registry, the second one is product registry. In the disease registries, all patients are enrolled because they show a specific disease, so it doesn't matter which kind of treatments, for example, they are taking. I was talking about the Swedish heart failure registry. This is a disease registry, is a registry on heart failure. So all patients with heart failure, regardless of treatments, other comorbidities, and demographic characteristics are enrolled. In product registry, we rather enroll all patients receiving a specific treatment regardless of indication. For example, if we want to focus on a registry on oral anticoagulant, for example, it doesn't matter why the patients are taking the anticoagulant. It's just important that they are taking the anticoagulant. So if they are using them for atrial fibrillation rather than venous thrombosis, doesn't matter. They will be enrolled as well. So in principle, when we build a registry, there is no testing or research hypothesis. It's just a collection of data. So there are three keywords for registry-based study that are observational studies run on registry. The first one is cohort studies. Indeed, they are cohort study. They enroll subjects with something in common, for example, same disease or same treatment, who are follow up over the time. We read this word quite often, real world. We use this word because these kind of studies are representative of real world patients' characteristics. This means that registry-based studies have less inclusion and exclusion criteria than randomized control studies. So they represent a little bit more the real world population, the patients that we meet in our daily clinical practice. So that's why we're here talking about real world studies. Registry-based studies are usually non-interventional, but a new philosophy of randomized controlled trials is currently run. It's called registry-based randomized controlled trials. So based on registry data, now it's also possible to randomize patients, so to have a registry-based study, which is also interventional. What does it mean, non-interventional study? Non-interventional study means that the investigational medicine products are used in accordance with the terms of the marketing authorization and the normal clinical practice of the state concerned. So, of course, in a registry-based study, we may be able just to test the association between a treatment that is already used in clinical practice and outcomes, but we cannot test new treatments. There is the assignment of the subject to a particular therapeutic strategy is not decided in advance. The decision to prescribe the investigational medicinal product is not taken together with the decision to include the subject in the clinical study, so the patient is receiving the treatment just because the patient has indication for that treatment. Diagnostic or monitoring procedure in addition to normal clinical practice are not applied to the subjects. So these types of study are really representative of the current clinical practice, since no additional procedure are applied. There are also there are different types of observational study. One is the cross-sectional design. In the cross-sectional design, we assess the association between a treatment and an outcome regardless of the follow-up. So the study will exist just in one specific time point, and there will be no follow-up evaluation. So for example, if we can consider this time point here, we assess baseline, we investigate here the study population, we select those patients who have and not have the disease, and there we assess which ones have the factor, the risk factor present or absent, and then we investigate the association. But this happens here. If we choose another time point, maybe the results may be difficult. So in cross-sectional study, we consider just one time point regardless of the follow-up. In prospective studies, indeed, we investigate patients. We assess baseline characteristics at the beginning of the study. We investigate how many patients report or not a specific risk factor, and then we have a follow-up. During the follow-up, we collect outcomes in patients who show and who do not show a specific risk factor. So here the follow-up is considered. For example, in registries, although studies can be also retrospective, of course, and in retrospective studies, sorry for that. In retrospective studies, the study begins here. We know how many patients have the disease and how many patients do not have the disease, and then we go back to the past to check how many patients had the risk factor or didn't have the risk factor, and we try to figure out if there is association. So each type of different study has merits and limitations. For example, for core studies, the merits are that there is a temporal relationship between exposure and outcome, whereas we have seen that for cross-sectional studies, for example, there is no consideration of follow-up. So this is a big difference. In a core study, we can investigate several outcomes for each exposure. It's possible to perform matching, limiting confounder's role. We will see this later. They are, of course, easier and cheaper than randomized controlled trials, and they are good to measure incidence of an outcome. The limitations are that these types of studies are expensive, although not as much as expensive as randomized controlled studies, but in any case, they are still more expensive, for example, as compared with a cross-sectional study. The outcome could take time to occur, so it may be difficult to get a good amount of outcomes collected in these studies. Definition of outcome and exposure could change over the time, particularly if the time frame considered is particularly long. There is no randomization, and so there are all the limitations linked with the lack of randomization, and there is no blinding or masking. Registries are also used in post-marketing surveillance. I think you talked about this yesterday, in order to evaluate short, long-term effectiveness, so day-to-day circumstances, measure, monitor short and long-term safety and tolerability, measure and or improve quality of care. And yesterday you had a presentation of this. So now I would like to focus a little bit more on registries, and I will show you how one of the Swedish registry work in order to provide an example of how to use this incredible tool for research. So we focus on the Swedish heart failure registry that has been created in 2000. It's an ongoing registry, so the enrollment is continuous. Also, right now, they are enrolling patients. So this registry includes both inpatients and outpatients at 65 or 75 hospitals in Sweden. This kind of registry has only one inclusion criterion, that's physician-judged heart failure. So it's a very broad inclusion criteria. There are not really exclusion criteria. So we may say that this is really representative of the heart failure population. The patient is informed of registration, and the patients can actively decide not to be enrolled, but no written consent is requested. So usually all the patients are included, because if patients have to choose to not to be included, usually they just don't care and allow us to register data. That's why we are able to collect information on 100,000 patients. So it works the other way around. In many other studies, you need to ask the patient to sign the informed consent. Here you have to ask the patient if he doesn't want to be enrolled. So it's just the opposite. So right now we have a little bit more than 70,000. We have around 100,000 patients enrolled in the registry. This is an heart failure registry, so it's important to collect ejection fraction. And we have patients with all types of ejection fraction. So we have patients with reduced, mid-range, and preserved ejection fraction. This is quite important when we want to run studies to phenotype heart failure patients. The coverage of incident heart failure is quite low, is 12%. The reason for that is that usually incident heart failure patients are seen in primary care or internal medicine, for example, and this type of care do not refer to the Swedish heart failure registry, but of course later these patients will be seen in cardiology department and so registered in the Swedish heart failure registry. This explains why the overall coverage is 54% and is higher as compared with the coverage for incident heart failure. So it's still lower as compared with other registries in Sweden. For example, SwedeHeart has almost 100% coverage, but this is but that's much older registry, so they have more experience and so on. So for 18, 19 years old registry, 54% coverage is not bad at all. In the Swedish Heart Failure Registry, we collect more than 100 baseline characteristics for patients. Some can be derived. We have some information on demographics, comorbidities, clinical characteristics. For example, we have information on X-ray, ECG, blood pressure, heart rate. We even have like laboratory measurements. So we have measures on creatinine, potassium, hemoglobin, NT-proBNP. But of course, we have just biomarkers collected in daily clinical practice. So we do not have more. We have also medications and doses for heart failure treatments. But what is very good in Sweden is that we can link different registries. So actually we can link the Swedish Heart Failure Registry with the National Patient Registry and get additional information on comorbidities by ICD codes. We can have socioeconomic information regarding these patients, linking the registry to Statistics Sweden, where we get information on education level of this population, number of children, for example. We get if they live alone or they are cohabitating. So very important information if we want, for example, to assess the use of treatments that may be influenced by the environment where the patient is living. And then we can link the registry even with the dispensed drug registry, where we actually get information about all the treatments, all the drugs that the patient is taking from the pharmacy. So not only treatments on heart failure that are also collected in the SwedHF, but also cardiovascular treatments more in general, and even non-cardiovascular treatments. It's even possible to link the Swedish Heart Failure Registry with cohorts of subjects without heart failure and completely healthy, for example. This is particularly important, for example, if we want to investigate incident heart failure, so we need a comparator cohort where there is no heart failure. So we can get control from another registry that is called Statistics Sweden, and we can even link the Swedish Heart Failure Registry with other disease registries, for example, the SwedHeart or a registry on atrial fibrillation and so on. For example, it may be important to link SwedHF with SwedHeart if we want, for example, to investigate post-MI heart failure, since in SwedHeart they enroll patients with myocardial infarction. We have whatever outcome we desire in the Swedish Heart Failure Registry. Indeed, we link SwedHF with other national registries where we can get information regarding whether patients are alive or died. We have cause of death. We can know whether patients were hospitalized and the cause of hospitalization. We can know whether patients had new onset of comorbidity, and we can check the medication adherence continuously. In SwedHF, there is minimal loss to follow-up. The reason for that is that patients are never lost to follow-up because they are somewhere recorded in hospital or demographic registries or wherever in other registries. Of course, patients are lost to follow-up if they leave Sweden, because at that point it's not possible to collect information on them anymore. But the vital status of these patients is always known. We have, till now, we have used this SwedHF for several research purposes. For example, we have used that for investigate potential treatment in FPAF. We have used to implement heart failure treatments more in general. We have used to phenotype FPAF and FMREF. We may use SwedHF to facilitate trial design, to perform international comparison of heart failure characteristics, and even to run registry-based randomized controlled trials. So let's see some studies performed on the registry to try to understand what we did. Here, it was some years ago, and there was a lot of discussion on which kind of treatments should have been used in FPAF. Trials were neutral, and there were some concerns regarding the trial design. for several of these neutral trials. So what we did was to investigate the association between RASI and beta blockers and outcomes in SWID-HF. And we could actually, in identifying the first paper published on JAMA in 2012, an association between the use of RASI and mortality in patients with FPEF that was not shown in randomized controlled trials, and it happened the same for beta blockers 2 years later, always published on JAMA. These were well-designed studies with propensity score matching that we will see later. But of course, yesterday I anticipated that although we may have propensity score matching, so a very good adjustment, this is not a randomized controlled trial, so we can investigate the association, but we cannot be sure if there was any unknown confounder, and so we cannot talk about the effect of a treatment, but just about the association. However, these results may be still hypothesis generating and may somehow foster the support the hypothesis of a role for the renin-angiotensin system in FPEF. Then we have also used the SWID-HF in order to assess subgroup of patients that were neglected in trials. For example, in FREF trials, the mean age was quite low. The mean age in FREF randomized control trials was 65 years old, and no patients in each of the FREF trial had age higher than 80 years old. So actually we have RAS inhibitors, beta blocker, and a lot of treatments approved for the whole FREF populations, but these treatments have never been tested in patients older than 80-year-olds. So it looks, since it looks a little bit impossible that today we run a trial on RASI in patients older than 80 years old, because from a, let's say, business point of view, this will be useless. We assessed this hypothesis in the Swedish heart failure registry, where we assessed the association between the use of RASI and outcomes in patients older than 80 years old. And as you can see in the figure, the first row, RASI significantly reduced in a propensity score matched analysis the risk of all-cause mortality and the risk of all-cause mortality or heart failure hospitalization. And the reduction in risk observed was similar to that observed in younger population. You can see in the second row a positive control analysis where patients younger than 80 years old were considered. So you can see that the reduction of risk was very similar, and the hazard ratio in the positive risk was 0.8. That was similar to the hazard ratio shown in randomized controlled trial. So we may speculate that if we reproduce this study in a randomized controlled setting, we may find similar results. The use of registries is also very important to investigate the use of treatments over the time. So here you can see the use of heart failure treatment in Sweden before 2002 and 2012. So although the use of RASI and beta blocker was quite high as compared with other countries, this figure shows us there is still some margin to improve. The use of MRA, mineralocorticoid receptor antagonist, was much lower and decreasing over the time. And this is a problem which is common both in Europe and in US. So these treatments are very much underused in heart failure patients. And also the use of ICD and CRT was very low, but we may consider that to implement the use of devices, some more time may be needed. we also investigated how many patients with heart failure and concomitant atrial fibrillation were receiving oral anticoagulant. These patients per se have chest vasc more than one, and according to the guidelines, they should receive oral anticoagulant. However, we observed that only 60% of this population was receiving oral anticoagulant, and the explanation for that was mainly the fear for bleeding. So physicians were more scared about bleeding rather than the increased thrombotic risk observed in this population. And we go back again to mineralocorticoid receptor antagonists. So in the previous paper, we showed that there was underuse. And in this paper, we try to understand the reason for underuse. And as shown in this forest plot, the major reason for underuse was actually decreased renal function, but although eGFR was between 30 and 60, so meaning it was not really reduced, there was already there a beginning of reduction of use of MRA. This means that as soon as we have a slight reduction in GFR, physicians start not to use MRA in heart failure patients anymore. And of course, other reasons for concern for using MRA in heart failure patients were low blood pressure and higher age, and actually less severe heart failure, female gender, and that was all. We have also used SWIDA-CHEF in order to characterize heart failure with mid-range ejection fraction, since this kind of phenotype has been introduced in the guidelines a few years ago, and not so much was known about patients with ejection fraction between 40 and 50, because they were constantly enrolled in randomized controlled trials. So in this paper, we tried to understand whether these patients were more similar to BEF or more similar to REF regarding ischemic heart disease. And we observed that actually FMREF patients are very much similar to FREF patients regarding prevalent and incident ischemic heart disease. And in this paper, we actually compared PEF, MREF, and REF for all the baseline characteristics recorded in SWIDA-CHEF and treatments, and we observed that patients with PEF, with MREF are intermediate between those with PEF and REF for several baseline characteristics, and they are more similar to PEF for some baseline characteristics, but they are extremely more similar to REF when we talk about ischemic heart disease. We even used SWIDA-CHEF in order to compare European heart failure and European heart failure population with heart failure population from Tanzania and Asia. And we observed that when we compare Sweden versus Tanzania, the difference in outcome is explained by, of course, different use of treatments. And we also assessed the different prognostic role of QRS prolongation in patients enrolled in Sweden as compared with those in Asia. And this was to further phenotype this kind of patients. The use of registry may be also important in order to support trial design. Here in the first paper, the one on the top, we actually showed that in patients with ejection fraction more than 40, a decrease in NT-proBNP over the time is associated with a reduction in risk of all-cause mortality or heart failure hospitalization. This means that the reduction in NT-proBNP may be a useful and a feasible surrogate endpoint for trials in HFpEF. And in the second paper, we investigated the relationship between continuous NT-proBNP level and risk of cardiovascular and non-cardiovascular event, because when we plan a randomized controlled trial in heart failure and we want to use NT-proBNP in order to enrich trials for cardiovascular for events, we want to have a threshold for NT-proBNP that selects patients at high risk of cardiovascular events, but at very low risk of no cardiovascular event, because non-cardiovascular event could prevent the occurrence of cardiovascular events, and our treatments want to solve cardiovascular but not non-cardiovascular issues. So here we show that in order to a feasible NT-proBNP cutoff in FREF may be a lower NT-proBNP level as compared with FPEF, because in FREF a lower NT-proBNP level is able to discriminate patients at high risk of cardiovascular events as compared with risk of non-cardiovascular events. Whereas, as you can see in FPEF, the curves are more or less overlapping, and in order to have this curve diverging, we need to have much higher levels for NT-proBNP. So in FPEF trials, higher NT-proBNP levels may be used in order to enrich the population for cardiovascular events. And finally, we even used the Swedish heart failure registry in order to run a randomized controlled trial. These types of trials are called registry-based randomized controlled trials, and I will try to explain you how it works. The rationale for these trials was to assess whether spironolactone was effective in improving outcome in patients with FPEF. There had been a trial on that was the TopCat trial, but there had been several complaints about the several concerns about the conduct of the trial. So after this trial, it was not sure whether this treatment was effective or not. Indeed, the sub-analysis showed that spironolactone was effective in the Americas, but was not effective in Eastern countries. And the reason for that can be just speculated and so on. We actually try to address this question building a registry-based randomized controlled trial on the Swedish Heart Failure Registry. This trial is called SPIRIT FPEF and is currently ongoing. So we enroll patients with FPEF, meaning with ejection fraction more than 40, so actually including also patients with mid-range ejection fraction. And we randomize patients to spironolactone plus usual care versus usual care alone. So we actually use the Swedish Heart Failure Registry in order to identify patients who may be eligible for the trial per se. When we identify patients who are eligible, they just need to sign the informed consent. We don't need to collect any baseline characteristic for these patients. I think you are all aware about the CRF we have in traditional trials where you have to fill in 1,000 papers and so on. Here it's not necessary because the randomization platform automatically extracts the baseline characteristic of patients from the Swedish Heart Failure Registry. So it's not needed. It's not needed to register a baseline characteristic of patients. And during the trial, just 3 or 4 compulsory visits are required, and these are required in order to actually collect potassium, since dyskalemia could be, associated with the use of the treatment, but no further visits are needed. The reason for that is that we follow up the patients in the registry, and if the patients has an outcome of the trial, we will get this information by the registry, so we will not need to collect outcome in this population. So it's a very pragmatic trial, very fewer inclusion-exclusion criteria, fewer compulsory visits, and this means that this kind of trial is much cheaper as compared with a traditional trial, and it allows to address important questions that are currently not answered. So in this slide, in this study, we summarized actually the advantages of randomized controlled trials, registries, and of registry-based randomized controlled trials. And when you compare these different types of studies, you get the following message. So in randomized controlled trials, you have randomized evidence. That's extremely important, but you have a lot of limitations. They are extremely expensive. They select a lot of patients. So there may be concerns about external validity and so on. In registries, you have like real world evidence. You have they are inexpensive and so on, but you lack of randomization, so it's just not possible to test the effect of a treatment on outcome. We can just talk about association, so they do not work as in interventional study. But if we have registry-based randomized controlled trial, we may have benefits that usually belongs to randomized controlled trial and registry. So we have randomized evidence. They are less selective than traditional randomized controlled trial. They are cheaper and they are simple. So this is a very pragmatic study design, and there are several trials like that at the moment ongoing, particularly in Sweden, and we plan in the future to export this kind of trial design also to other countries in Europe and also in US. So, what time is it? Okay. So we start to talk a little bit about statistical issues that we may have when we run registry-based study, observational studies, and then we will talk about meta-analysis. Are there questions till now? No? Okay, you will have questions later, I hope. Yesterday we talked about confounders. So when we have a risk factor, usually there is an intermediate phenotype, and later we may register an outcome. This means, for example, that if we have high cholesterol levels, maybe if we are very unlucky, we develop atherosclerosis, and later, if we are even more unlucky, we develop coronary artery disease. It may be the same with diabetes, so the risk factor is diabetes, the intermediate phenotype is atherosclerosis once again, and disease or final outcome is coronary artery disease. But sometimes the association between exposure and outcome is not that simple, and there may be another variable that has an impact on both the exposure and the outcome, and this variable is called confounder. For example, if we consider, as I say, coffee drinking, we may see that a lot of, there is an association between using coffee and the occurrence of pancreatic cancer. But patients who drink coffee are more likely to be smokers, and smoking is a risk factor for pancreatic cancer. So this is the typical confounder that has an effect that is associated both with the exposure and the outcome, and drives the association between the potential risk factor and the outcome. For example, in this study, the authors assessed the association between LDL cholesterol, triglycerides, HDL cholesterol, non-HDL cholesterol, triglycerides, and risk of coronary artery disease. So in the first figure, you can see that when analyses were adjusted for age and sex only, there was a very nice dose-dependent association between triglycerides levels and risk of coronary artery disease. However, this association may be influenced by something else. For example, from LDL cholesterol. It's very likely that patients with high triglycerides level may have also LDL cholesterol, high LDL cholesterol. That is a major determinant of coronary artery disease. So when we adjust also for these other variables, we see that the very nice association that was dose-dependent is not there anymore. So part, at least, of the association was explained by a confounder. That's the reason why it's always important to consider confounders in observational studies. So the criteria to be a confounders are the following. The confounding factor must be associated with both the exposure and the outcome. The confounding factor must be distributed inequally among the study groups, and a confounder cannot be an intermediate step in the causal pathway from the exposure to the outcome of interest. For example, atherosclerosis is not a confounder, but is only an intermediate pathway, so we don't have to adjust for atherosclerosis when we assess the association between, for example, diabetes and coronary artery disease, because that's just the intermediary step. So how to solve the problem when we want to run a registry-based study or observational study? And there may be confounders, and we have to be able to try at least to limit the influence of these confounders on the analysis. There are two major approaches. One is to use multivariable models. That's what I think all of you are aware about this. And the second one is to use matching. And in the last year, using propensity score matching has become a really, I will say, trendy way of trying to solve this issue. So I will try to focus a little bit on the propensity score and try to show you how it works to have like matching using the propensity score. First of all, what is a propensity score? The propensity score is defined as a subject's probability of treatment selection conditional on observed baseline covariates. It looks very difficult, as usual, because it's a definition, but it's very simple. For example, we can explain it like that. A propensity score, first of all, is a number, and it's a probability. So it's a probability that a patient receives a specific treatment due to his or specific baseline characteristics. For example, let's consider a treatment, for example, digoxin. Who are the patients who are more likely to receive digoxin if we talk about heart failure? Of course, those patients are those who are sicker. So if we match two patients with two similar propensity score, we are going to match two patients who have a similar level of confounding. We can explain in that way, because they have the same probability of receiving the treatment because they had that kind of illness, they had that kind of heart failure severity, because they were receiving specific concomitant treatments, because they had specific concomitant comorbidities. So they had the same probability of receiving the treatment of interest based due to comorbidity, other demographic characteristic, meaning confounders. Is this clear? Is this clear? Okay. So actually, the point is that if we match patients with similar propensity score, it looks like these patients will be similar. So we can rule out the presence of important confounding. So how do we need to match these patients? There are different ways of matching patients using the propensity score. The first one is the nearest neighbor matching. That means matching to a given treatment subject that untreated subject whose propensity score is closest to that of the treatment subject. Is it possible to write somewhere? No, unfortunately. So it means that if we have like 10 subjects, 5 receiving a treatment and 5 receiving a control, we try to match patients belonging to the treatment arm with those belonging to the control arm who have more similar propensity score, right? So they are more similar one to the other one. The second way to do that is to use the nearest neighbor matching within a specific caliber distance. What does it mean? This means that we define a caliber. For example, we define a caliber of 0.1. So if we have patients in the study group A with propensity score 0.9, we can match all patients in the study group B who will have propensity score between 1 and 0.8, because the caliper is 0.1. Is this clear? So we define a range, and patients from the second group can be enrolled, can be matched with the patients in the first group, whether their propensity score is included in that range, right? So if it's 0.8, for example, the propensity score in group A and the caliper is 0.1, from the group B, we can take patients with 0.75, 0.73, but not lower than 0.70, because this is out of the caliper, or patients who do not have propensity score higher than 0.9, because this is out of the caliper. Is this clear? Okay. Another way to match patients according to the propensity score is to stratify the population according to the propensity score. For example, we have 100 patients. We consider some of these patients are receiving the treatment A and some of the patients are receiving the treatment B. We calculate, I don't know, quartiles, for example, and then we can match patients who are within the same quartile for propensity score, okay? Because they will have more similar propensity score, right? So the overall idea is to try to match two patients who have a very similar propensity score. So if we do like that, this means that basically they will be very similar for all the baseline characteristics that had been considered in order to calculate the propensity score, right? Because yesterday we say that we select the variable to calculate the propensity score, so we are actually deciding for which are the important baseline characteristic we want to match for, correct? So we adjust for known confounders, but of course this is not an equivalent of randomization, so we will not adjust for unknown confounders because they will be not included in the statistical models that we use in order to calculate the propensity score, okay? And then let's see an example of this type of studies. Here we have two studies that have been run on the same data set that was the AFFIRM randomized controlled trial. And these were two sub-analyses, testing the association between use of digoxin and outcomes in patients enrolled in the AFFIRM study. As you can see, both groups use the same population and they assess the same research question, and these two papers were published on the same issue of the journal. So the point is, why to do something like that? The point is that they got two different results, but they were using the same patients. And so basically here the issue was not if digoxin was reducing or not the risk of mortality, but the issue was what is the right method to be used, because if we use one method rather than another one, we may have different results. And in one study they were using multivariable adjustments, and in another study they were using propensity score matching. And I'm showing you this to understand together the pros and cons of using each of these two methods. So let's see the first study that was published by Whitebeck. So they consider the AFFIRM study population. It's not important to talk about this trial. It's just, it's not relevant for our aim. So within this population, they identified patients who were using digoxin and patients who were not using digoxin. In this trial, patients were not randomized for digoxin use. So this was like an observational study, okay? They assessed the use of digoxin at the baseline, and they got 2,000 patients using digoxin and 1,900 patients not using digoxin, and they assessed the outcome that was mortality, I guess, over the follow-up. So very simple study design. So these were the baseline characteristics of these patients. As you can see from the p-values, these two groups of patients were completely different for almost all the baseline characteristics collected. And this is obvious because patients receiving digoxin are usually sicker. Most of them may have, for example, heart failure, so they may be even sicker. And patients with not using digoxin maybe had no heart failure or had overall like better baseline characteristics. So here you really understand that there is a major problem when we want to assess the association between digoxin and outcomes, because these two groups are completely different. So there may be a lot of confounding. So what did the authors do? They had like Kaplan-Meier, and in their Kaplan-Meier they showed that mortality associated with digoxin was much higher as compared with those who were not receiving digoxin. And these were crude analysis, and they did like multivariable adjustments, and they came out with the same results. So in this first study, the use of digoxin was associated with increased risk of mortality, okay? Then this second group of authors assessed the same aim in the same population with a different method. So they consider once again the affirmed population, and then they stratify the population according the use of digoxin, and then they did the propensity score matching. And as you can see, they came out with two study groups consisting of around 900 patients. But how many patients were using and not using digoxin before matching? So before matching, there were around 2,000 patients in each study group. After matching, there were 900 patients in each study group. So this is a first important point we need to discuss. So since these two groups of patients, those receiving digoxin and those not receiving digoxin, were very different, it was very different to match them, because it was very possible that a patient using digoxin had no patients not using digoxin who could be matched, because the baseline characteristics were so different. So maybe propensity score values in patients receiving digoxin was like 0.9, but in patients not using digoxin it was 0.5. So completely different numbers, and so not all patients receiving digoxin could find a patient with a similar propensity score in the control group. So that's why there was like a highly selection of patients when the propensity score matching was performed, okay? These figures reports actually the baseline characteristics before and after the matching. The black dots are after the matching, the white ones are before the matching, and here on the x-axis it's calculated like the difference in baseline characteristics between these two groups of patients. And as you can see, after the propensity score matching, the differences were close to zero, so the patients were very well matched. So once again, these are the baseline characteristics before and after the matching. Before the matching, the groups were completely different, but after the matching, they were similar for almost all the baseline characteristics, so very comparable populations, okay? So once again, Kaplan-Meier curve, and there was no association between digoxin and mortality. So now the point is, digoxin is associated or not with mortality in this cohort of patients. This is hard to be said. First of all, once again, this is not a randomized controlled trial, but it's an observational study. So in any case, we could not say anything like that. But another point is which one is the correct method to be used in this population? What would you think? Do you think it's better to use the propensity score matching in this population or to use multivariable models? Why? You think you address better the presence of confounders and the differences between the groups? This is true, actually, but one point is it correct to select a population so much when we need to perform a propensity score matching study? Actually, we just use the 50% of the population. So this is another point that may be considered. And for example, what we do in our studies on the Swedish heart failure registry is to use both methods. So actually, we do like that. We have unadjusted models, for example. Then we calculate propensity score matching. That's a number, a probability. And then we adjust for the propensity score. So we do not match the groups, but we have multivariables models adjusting for the propensity scores. That's just the number, but includes, you know, all the baseline characteristics inside, right? So we do that, and after that we perform the matching. And we try to see if there are dissimilarities between the methods or not. Usually there are not. What we usually observe is that if there is an association, it's much weaker after propensity score matching as compared with multivariable models. But if there is a difference, we may also consider the kind of selection we perform in order to run the propensity score matching study, because if we select so much the population, maybe we are missing some important things. So these are all important elements that have to be considered when we choose the study design and the statistical analysis to be used in our observational study. And another important issue that has to be considered is that if there is any bias, in this case, for example, may be indication bias. So patients were using digoxin, but why were they using digoxin? Just because they were sicker. So this is important. Or they may be reverse causation. What does it mean? This means that we showed that digoxin patients, digoxin was associated with increased risk of mortality, but maybe patients were used digoxin because they were expected to die more. So patients who were sicker and had higher risk of mortality because they were sicker were using digoxin. So this is reverse causation. It's the use of digoxin because we expect a higher risk of the outcome, right? Correct? So after the publication of these two very nice studies, there was an editorial, and the title was "When Digoxin Use is Not the Same as Digoxin Use." That's a statistical lesson from the FIRM trial, and here the differences were discussed. So they were both non-randomized observational analysis, because although they use a population from a randomized controlled trials, patients were not randomized for digoxin or not digoxin, but for something else. So it was still an observational study, so confounder was important. In the first study, the one not using the propensity score matching, they used time varying covariate throughout the study. It means that they also consider whether patients at the beginning were using digoxin and then during the study stopped to receive digoxin, and the other way around. So this was an information that they could use by considering like multivariable models, whereas in the study using the propensity score matching, the use of digoxin was fixed at the baseline. So if patients were receiving digoxin at the baseline, they were considered as receiving digoxin for the whole follow-up of the study, although they were not considered digoxin anymore. But this could seem worse as compared with the first approach. But if you consider randomized controlled trials, there you use intention to treat analysis, and it's actually the same. In the first study, the one using multivariable models, they used the full cohort, so it was 4,000 patients, whereas in the second study, they selected a lot the cohort, so they had less than half of the original cohort. So they used a very good method for the adjustments, that's propensity score matching, but they lost almost more than 50% of the population. In the first study, they used adjustment, whereas in the second study, they used matching. And the results, as you can see, were completely different. So in the first study, there was a 40% statistically significant increased risk of mortality associated with the use of digoxin. Whereas in the second study, the hazard ratio was just 1, so it was completely neutral. So also the conclusions of these studies were completely different. This means that these studies have no conclusion. I mean, the aim of showing you this is just because when you read papers, it's always important to read methods and to critically think about the methods that have been used. Because if reading these two studies, they could seem both very good from a statistical point of view. But you see, there are a lot of statistical consideration behind them that may lead us to consider one more or less relevant than the other one. So this is what I wanted to explain to you regarding observational studies and registries. So if you have questions, you are more than welcome, and then we can proceed with meta-analysis. Please.
How do you define the propensity score? Like, for every variable, you give a score of 1, 2, 3,
Mm-hmm.
and there is a total sum?
Yeah, that's a very good question. So it works like that. So as I say, the propensity score is a probability. So it's a probability that you give to each of the patients in your study population. How to calculate this probability? You use logistic regression models, and within this logistic regression model, you include the variables that you think should be considered for the matching. So as you can see, here you select the variables that you want to use for calculating the propensity score matching. So actually, you are adjusting for known and for known confounders. So that's the difference with the randomization, where you just use a coin and you have 50-50 probability to be randomized to a group rather than another one. So there you do not have measured and unmeasured confounders. So the statistical way to calculate propensity score matching propensity score is to use logistic regression models in which you include the variables that you think are relevant in order to calculate the propensity score matching. When I do that, I usually include like demographic variables, I include comorbidities and important treatments. You may think that as much variables exclude, better it is, but there is always the risk of overfitting a model, so it's bad to have like a logistic regression model with 100 variables inside. So that's why you need to choose carefully the variables in order to have, you know, the right amount of variables, but also the right amount of information that you want to adjust for. Is there any other question? Good. So now we talk about meta-analysis and systematic reviews. First of all, this is a definition for systematic review. Systematic review is a review that is conducted according to a clearly stated scientific research method and is designed to minimize biases and errors inherent to traditional narrative reviews. why is it important to run a systematic review? For two reasons. The first one is to have like one paper summarizing all the current literature regarding one specific issue. And the second one is that sometimes we have several studies exploring the same issue, but they have conflicting results. So we try to compare them and, if possible, perform a meta-analysis and see what is the overall estimates in all the studies performed in this for this specific issue, and we will see this later. So when we plan a systematic review, there are two possible approaches. The first one is to perform only a systematic review, which is a qualitative synthesis. This means that we just describe the studies that we have identified by a literature search. And the second one is to perform statistical synthesis of the data, which is called meta-analysis. But this is not always appropriate and possible. We will see when this is possible. The hypothesis when we want to plan a systematic review and the meta-analysis has to be conceived a priori, which is similar to what we do for all the different types of studies. There are 4 steps when we want to perform a systematic review and a meta-analysis. The first one is to identify the studies, which is the most important part of the work, although it seems to be the easiest one. I think it's the most difficult thing to be done. The second point is to fix some inclusion and exclusion criteria for the trials to be included in the systematic review and the meta-analysis. After we identify these studies, we need to abstract data from these studies, and then if it's possible, we need to pool data that we have identified by the literature search. We will see how to do this. So first point, literature search. So the literature search strategy has to be defined a priori. It cannot be, it cannot change during the literature search per se, just to include what we like more or what we like less. It's wrong to use just one data set. So PubMed is not the Bible, and we need to use several databases, because some studies could be published on one data set, on one database, but not on another one. It's true that when we consider a trial published on the New England Journal of Medicine, it will appear on all the databases, but maybe smaller studies will be published on one database, but not on the other one. So when we want to perform a systematic review and or a meta-analysis, we may use more than one database. I usually use like 3 or 4 of them, like PubMed, Cochrane Review, Easy Web of Science, and Scopus, usually. And then we also have to consider that there are also other potential sources for studies. A very good one is trial registries, clinicaltrial.gov. Sometimes trials are concluded, so the enrollment is ended. There are even results, but the paper has not been published yet. But the data are published on clinicaltrial.gov. So it's very important to check this data set. And of course, we can even extract data from abstract, from meetings, and other references, although we have to consider a lower quality of, for example, an abstract analysis as compared with a full paper analysis. Sometimes it happens that, for example, analysis published on abstract from meetings are preliminary, and then later on the full publication, results may be a little bit different because they change something. Be careful with risk of bias. There are different biases. The English language bias happens quite often because papers in languages other than English are more likely to be excluded. And it can happen that you find publications in languages that are not English, and you should translate them and see if they are relevant for your meta-analysis. The citation bias. Studies with a significant or positive result versus those with inconclusive or negative results are more likely to be referenced in other publications, so they are more likely to be identified. So, for example, if a paper has been cited by a big trial published on the New England, it's more possible that you will check the references from the paper on the New England, and then you will identify also this trial, rather than if a trial has been cited by a very small local national journal, and it's less likely that you will check the references from that study. Publication bias: studies with positive results are more likely to be published. That's why yesterday I said it's important to try to publish everything, although the results are not positive. Data collection. The variables of interest and thus the list of data to be extracted should be decided a priori. A data extraction form should be used so that the same data are extracted from each study and by all the reviewers. And it's important that at least 2 independent readers should perform the literature search and the data extraction in order to be reproducible and accurate. So usually 2 people independently perform the literature search, and they independently extract the data, then they compare the data and they see if there are discrepancies. If there are discrepancies, they can try to find an agreement, and if they don't find an agreement, a third reviewer should be involved. Which kind of data we need to extract in order to perform a good meta-analysis systematic review? Study characteristics, for example, year, journal, publication, number of patients in each arm, treatment performed, duration of follow-up. Demographic characteristics, clinical characteristics, of course, outcomes. And of course, this depends on which kind of outcomes you want to collect, which kind of clinical characteristics you want to collect, depends on the type of topic you are going to explore. Then it's important to assess quality of the studies included in the systematic review and meta-analysis, because of course you are going to pool data, and if you are pooling data from very poor publication, you will get a very poor meta-analysis. So the validity of a systematic review depends on the scientific method of the retrieved studies and the reporting of data. So you can actually assess the quality of the studies, including the meta-analysis, using several tools. One of these is the grade. Actually, you have a flowchart, and according to the points reported in this table, you can give a score to each of the papers or each of the studies that you are going to include in your meta-analysis. Then you can have a data synthesis, so you can use an analytic approach, which is a meta-analysis. So go from a systematic review to a meta-analysis in very specific cases. This can be done if the studies you are aiming to pool are not too different from each other. Otherwise, you are pooling like apples and bananas, and the result makes completely no sense. So it's always important to consider if the studies are enough similar for outcome definition, population size, population characteristics, intervention. And if there are differences for these points, it means that you have heterogeneity, and heterogeneity has always to be assessed and considered when you want to run a meta-analysis. Let's try to give some example. Outcome definition. If you have like trials on a very specific topic, and the primary outcome of the trial in these several trials may be different. So does it make sense to pool the primary outcome of several trials, although all these trials are focusing on the same topics? Sometimes the primary outcome of the trials are composite outcomes. And in most of the cases, these primary outcomes include different outcomes. So they are calculated in different ways. So does it make sense to pool a study where the outcome is the composite of cardiovascular mortality plus myocardial infarction, together with a study where the primary outcome is stroke or, I don't know, leg revascularization. No, it makes completely no sense. So it's important to check the definition of the outcomes that we want to use in our meta-analysis. Then population sizes. If we have 10 studies, one has 100 patients and 9 studies have 10,000 patients, does it make sense to pull all this stuff together? Maybe yes, of course, the influence of the small study will be very limited. But if we have 10 studies and 9 of them have 100 patients and one study has 10,000 patients, do you think it makes sense to combine them? You will get an overall estimate that will be the same of the big trial. So this will be a useless meta-analysis, and there are 1,000 meta-analyses like that actually published, where the overall overall estimates is explained just by one trial. So what to do in that case? At least try to repeat the meta-analysis excluding the trial and see if you get the same results. And then, of course, it's important to check population characteristics. Does it make sense to include in the same meta-analysis a primary prevention population together with a secondary prevention population? So you have completely different stuff. Does it make sense to pull it together? Maybe no. And of course, also the intervention. It's very important to check that you are pulling something that's comparable. If it's not, you have heterogeneity. But how to assess heterogeneity? It's just a philosophical concept, or it's something that we can measure? We will see this later. So what is a meta-analysis? It's a quantitative approach for systematically combining results of previous results to arrive at conclusions about the body of research. There are protocols published for meta-analysis. One of the most important is the PRISMA. And it's always important that you check this protocol because it actually explains you how to write the paper and how to run the meta-analysis. And if you follow all these items, you will get a very high quality meta-analysis because you will know how to describe all the statistical methods and how to report the results. So I really invite you to read the PRISMA checklist and to use the flow chart. We skip this. So there are two main statistical models when we want to run a meta-analysis: the fixed effect model and the random effect models. We use the fixed effect model when the effect of the treatment is the same for every study. This means when there is low heterogeneity. We use a random effect model when there is heterogeneity among the studies. And if you run a random effect model, you will get an overall estimate that has a larger 95% confidence interval. And this will mean that if the result is still statistically significant, you can be more confident about your result because the 95% confidence was larger and it didn't cross the one line. So you can trust more the results. So an overall guideline is to use fixed effect model with low heterogeneity and random effects model with high heterogeneity. How to measure heterogeneity? There are two types of heterogeneity. The first one is a clinical heterogeneity. That means variability in the participant intervention and outcome studied. The second one is methodological heterogeneity. So it's variability in study design. What does it mean? It means that you will find a lot of meta-analysis where they combine observational studies with randomized controlled trials. And this is a source of heterogeneity. And there, you can make like 1,000 different considerations. For example, you are pulling together studies where confounding is not a problem with studies where confounding is a problem. Does it make sense? This is a source of heterogeneity. I always suggest to maybe you have some specific reasons to pull this different stuff, but if you do it, then perform a sensitivity analysis. Just pooling randomized controlled trials and observational studies independently. So you see if the results are consistent. If you have clinical heterogeneity and methodological heterogeneity, you may have statistical heterogeneity that you can measure. How to measure statistical heterogeneity? And this is important Also, if you are not interested to run a meta-analysis, but you are just approaching to read the meta-analysis, always check these two parameters. The Q statistic, which gives a p-value. If this p-value is statistically significant, it means that there is significant heterogeneity. So this is one of the few cases where you don't want to have a statistically significant p-value. Remember that. And the p-value, which has to be considered statistically significant, has to be defined a priori, because it can be 0.05, but it can be also 0.1. So it has to be defined a priori. And then if the p-value for this Q statistic is lower than that threshold, it means that you have statistical significant heterogeneity. And then you can even quantify statistical heterogeneity by the E-square statistic. You get a percentage, and usually if the percentage is more than 50%, it means that you have substantial heterogeneity. But the question is, we will see this tomorrow, later. The point is, if you have statistical heterogeneity, what to do? Just trash the whole study? No, there are different tools that you can use. The first one is check again that the data are correct. This is the most important thing, because it happens quite often just to write a wrong number, and that number will be much different as compared with all the other numbers, and you will get statistically significant heterogeneity. The second one, that's the worst, is not to run a meta-analysis, because you realize that the populations and the interventions and the study design is so different across the different studies that just makes no sense to run a meta-analysis. Another point is to explore heterogeneity. So it's possible to perform subgroup analysis. For example, if you have a meta-analysis including studies focusing only on diabetes and studies focusing only on hypertension, it makes sense maybe to run a subgroup analysis and to assess the effect associated with the treatment only in patients with hypertension and only in patients with diabetes, and see what happens, because this may explain your heterogeneity. Another point is ignore the heterogeneity if there is nothing else that you can do, of course. But in that case, run a random effect model that has broader 95% confidence interval, so it's much better. And if you have like an outcome measured in different way, it's important to have it measured on the same scale. If it's not, this could be like a source of heterogeneity. For example, if you have 6-minute walking test measured in meters and in millimeters and kilometers, it should be the same for everything. Another important point is to try to exclude the studies that could explain the heterogeneity. For example, I was running a meta-analysis on treatments in heart failure, and I got significant heterogeneity, but then I realized I had 9 trials on pharmacological treatments and 1 trial on devices. And the trials on devices are completely different as compared with those on pharmacological compounds. So I excluded that. I ran an overall analysis that was statistically significant, but with heterogeneity. Then I excluded that study. I ran again the same analysis, and it was still statistically significant, but there was no heterogeneity at all. So I explained the heterogeneity, then I excluded the study. I got the same result. So I'm confident with showing the meta-analysis including all the studies, because there is heterogeneity, but I know why, and I can discuss on that. So also very important always to run a sensitivity analysis. How to do that? It's possible to run a one-study removed meta-analysis or a meta-regression analysis. What is a one-study removed meta-analysis? If I have 10 studies, a meta-analysis with 10 studies, I can run 10 meta-analyses, excluding in each of those 1 different study. Why do I do that? I do that because if the evidence is solid, if my meta-analysis is very good, excluding each of the 10 studies, I will get the same result. if I exclude one study and I have a completely different result, it means that the whole result was explained by that study. So this meta-analysis I'm running may be not very solid. And another important tool is to use a meta-regression analysis. Using a meta-regression analysis, I can assess whether the results of my meta-analysis is influenced by baseline characteristics of the studies included in the meta-analysis. It's like performing adjustment in a traditional observational study. Of course, if you have a meta-analysis of randomized controlled trials, it's more likely that you will not find any baseline characteristic having an effect on your results. Then always assess the presence of publication bias. This is a funnel plot. When you see this kind of figure, if these dots that represent the different trials are symmetrically distributed, it means that there is no publication bias. If they are asymmetrical, this means that there may be publication bias. But of course, the publication bias can also be assessed by a statistical test that's based on regression analysis. If you have a significant p-value for one of these tests, it means that actually you have a publication bias. So for now, this is, the basic for meta-analysis. If you have questions, please ask, and then I will show you how to perform a meta-analysis on a statistical software that may be nice, and to discuss the results we get.